of Ophthalmology session, and the title is the updates on the diagnosis and management of Asian eye diseases. We know that there's quite a lot of diseases that specifically affect Asian people, so we just hope to have a good session, really exploring some of the updates on the diagnoses and management of these diseases. I'll start first, and the first up is my talk, and it is on non-invasive imaging for polypoidal choroidal vasculopathy. Yes, actually, it's a continuation of yesterday's talk. It's a bit more detailed because I have more time here today. So thank you for coming, for those that are coming here. We wanted to talk a little bit about the diagnosis and management of PCV with non-invasive imaging. So you can see that this is the outline. Essentially, we're looking at how we can classify AMD, typical AMD versus PCV. And we want to look at the multimodal imaging for the diagnosis of PCV. We want to differentiate PCV from typical AMD. And we want to have multimodal imaging to monitor treatment response in PCV. So firstly, we need to know some background. I mean, this is everybody knows that PCV is an Asian subtype of AMD. It is the identification of PCV lesion allows the differentiation of PCV from typical AMD and has implications for treatment because, of course, with PCV, you may need second-line therapy like PDT or focal laser. PCV affects people in all ethnicities, but more prevalent in Asians, and is up to even 55% of Asians have PCV. It is a subtype of wet AMD, and you can see that it's characterized by abnormal choroidal vascular networks ending in polyps, and it's considered to be a subtype of wet AMD. The clinical features include serosanguinous maculopathy, few or no drusen. You can see the imaging features look like polypoidal dilation, the branching vascular network, and a thickened choroid and peripapillary lesions. This is the example of a multimodal imaging of PCV. You can see there's everything from color fundus photos to multicolor to fundus autofluorescence. And you can see the OCT and is especially useful for the diagnosis of PCV. Of course, FFA is also done, and ICGA is the gold standard. And you can always see that polypoidal lesions consist of the polypoidal lesions themselves and the adjacent branching vascular network that you can see in the blue arrows. ICGA remains the gold standard for PCV diagnosis. And you can see here in the early regions, you can get the hyperfluorescent lesions, your orange subretinal nodule, massive submacular hemorrhages, a pulsatile polyp, and you can see at that bottom, that polyp is pulsatile, nodular stereoscopic appearance, hypofluorescent halo, and branching vascular network. But ICGA, of course, is costly, invasive, and a lot of places don't have it. There's example like the Heidelberg Spectralis costs $50,000 to purchase. The cost of the dye is a lot. And of course, it's off-label in some countries. And ICG has some risks, which includes, cardiac arrest, and it needs a crash cart when you do ICGA. So what are the alternatives to ICGA imaging for PCV diagnoses? You can use color fundus photos, multicolor imaging, OCT, as well as fluorescein and OCTA. Today we will be focusing more on the multicolor, OCT, and OCTA. You can see how to differentiate between typical AMD and PCV. In typical AMD, you can see the ICG has a plaque, whereas in PCV, you can see these pinpoint hypercyanescent images with a branching vascular network. And what happens when you don't have ICGA? You can see the OCTA helps you a lot because on the left, in typical AMD, you get a multi-layered PED, but on the right, you can see a peaked PED with a branching vascular network. Color fundus photo and multicolor imaging can help, and we published a paper looking at PCV characteristics, and this can be identified by subretinal red-greenish nodules, a fibrovascular PED, massive subretinal hemorrhage, and a peripapillary location. And you can see there's no large drusen, which is a marked feature of PCV versus typical AMD. So what is multicolor imaging? Multicolor imaging is using a confocal scanning laser ophthalmoscope and three different wavelengths of light superimposed on each other to form a multicolor image. And we also looked at how we can diagnose PCV based on multicolor imaging and color fundus photography. And you can see that in our case, the polypoidal lesion is detected in about 50% of all cases, and both modalities, both color fundus photo and multicolor, are comparable for the detection of pathological features of PCV. But it only does it in half the cases, so that's not great. However, OCT is much more specific and sensitive, and the presence of these three features you can see here: multiple PEDs, the sharp peaked PED, the PED notch, and a PED notch is actually the notch when you go on the curvature on the cross-section of the PED. So when there's a large PED, it's when there's a dimple on the PED. A PED notch on fast imaging is different because that looks like sort of the inside of a bean on the on fast, but the notch on the OCT is a little bit different of a sign. So anyways, you can see here also the rounded hyporeflective area with the polyp lumen that you can see in some of these pictures over here. These are also very typical of PCV. So you can see that OCT is an effective alternative to ICGA, and it's also widely available, and the high sensitivity and specificity is used when it's used alone to diagnose PCV. And then you can see we've already come up with a nomenclature by the APOIS PCV work group, and these are the few characteristics, like I mentioned before, that is typical of PCV: the sub-RPE ring lesion, the on-fast OCT complex, the sharp peaked PED, and the minor criteria is the complex or multilobular PED, the thick choroid, the double layer sign, and the fluid compartment. So when you combine modalities, you can even get more sensitivity. So a combination of color fundus photo and OCT can also help the diagnosis. And in this paper by one of our colleagues, Vorapon, she has shown that there's high sensitivity for PCV diagnosis when you combine both color fundus photos as well as OCT. And the addition of FFA did not help the diagnosis of PCV. So one of the most common PCVs have branching vascular networks is with a type 1 neovascularization, which is underneath the RPE. But PCV can also occur with other types of neovascularizations. You can see here, this is the PCV lesion. This is the type 1 branching vascular network. In the secondly, you can also get PCV with a type 2 network, and in this case, you can see the PCV lesion here and the subretinal hyperreflective material that is the type 2 lesion. So the STREM is in the yellow arrows, and the green arrow shows the PCV. Also, you can get PCV in combination with RAP, a type 3 lesion. So in this case, you can see this is the RAP lesion, which is the intraretinal lesion, and you can see there's an adjacent PCV underneath it. And what else can we have in our armamentarium of multimodal imaging? We have OCTA also, and OCTA can help with the diagnosis. You can see the OCTA here that shows a hyperflow lesion where the PCV is and an adjacent branching vascular network. And the PCV is here seen as a hyperflow structure on OCTA, but this is not always the case. In 75%, actually, the polypoidal lesion on OCTA may show up as a hypoflow structure and not a hyper one. And this is really because I think the flow in the polyps may not be fast enough to reach the threshold of the OCTA, and hence the BVN is always showing up, but then the polypoidal lesion itself may not. And you can see that's what I mentioned. It's a hypoflow structure, so it's not bright in 75% of the cases, but in 25% of the cases, it is bright. And the BVN is always quite well seen on OCTA. So when you combine the detection and the diagnosis of PCV with OCT and OCTA, you can see these 2 out of 3 signs where we looked at, which is a PED, a notch or narrow pigment epithelial detachment around pigment epithelial structure, as well as on OCTA, the cross-sectional OCTA is the most useful one because you can see the hyperflow signal. It may or may not always translate to the on-fast OCTA, but that depends on your algorithm. So you can see this actually achieves an 82.6 sensitivity and 100% specificity for detecting PCV. So together, these two modalities are the way forward for non-invasive imaging. And not only that, but multimodal imaging can also monitor response to PCV therapy. To therapy in PCV. This is a 50-year-old Chinese male. He had left blurring of vision. You can see a nice peak PED with a little bit of the ring treat the patient, what happens? So at baseline, he's 619, 3 aflibercept later, and you see there's very nice regression. The polypoidal lesion is gone, even though there's some branching vascular network still there. So this is complete polypoidal regression, where the polyp goes away on ICGA, the PED flattens, and there's fluid resolution. And however, you can see that when we image polypoidal closure with ICG, it is an important outcome measure. You can see some of the different outcomes. In this case, after 3 aflibercept injections, the polyps are still there and they're persistently perfused. Whereas when you compare the case I showed you before, after 3 aflibercept injections, in that case, the polyp totally regressed, and these are closed polypoidal lesions. And why is polypoidal lesion closure an important outcome? It is an outcome that has not been recognized so many times with the treatment of PCV in the past before, because people just look at visual acuity and OCT and fluid. However, it is an important outcome because we know that open polypoidal lesions have been associated with devastating visual outcomes due to large hemorrhagic PED, submacular bleeds, breakthrough vitreous hemorrhage, and RPE rips, which are less common, but still a problem. So treatment implications for persistently perfused polypoidal lesions include more intensive anti-VEGF treatment to achieve polypoidal closure, long-term maintenance of anti-VEGF therapy, and a surveillance to make sure that new polypoidal lesions are not appearing. Also, to consider adding combination therapy with either PDT or for extrafoveal lesions, focal laser, and the need for more vigilant monitoring. You can see in this case, apart from what we presented before, where OCT can be used to diagnose PCV, it can also be used to assess the polypoidal lesion status after treatment. And some of the major criteria is if the polypoidal lesion has a dense hyperreflective appearance, like you can see on the top right picture at the follow-up of 12 months, and the absence of SRF and the absence of the subretinal hyperreflective ring, this shows that the polypoidal lesion is closed. Minor criteria include the distinct RPE above the PED, the absent PED, absence of IRF, presence of fibrovascular PED, and a decreasing maximum PED height and increasing hyperreflectivity of PED contents. So in summary, you can see that multimodal imaging can not only diagnose PCV and differentiate it from typical AMD, but half of the PCV can be picked up with color fundus photo and multicolor imaging alone. With the addition of OCT, you can get high sensitivity and specificity to pick up PCV. FFA shows some features of PCV, like its activity and leakage, but it's less specific for the diagnosis of PCV. And we can use multimodal imaging to monitor the treatment response in PCV, and the activity of PCV can be detected on OCT, FFA, and ICGA, and polypoidal inactivation or regression can be detected on OCT, OCTA, and ICGA. So future considerations: can our multimodal imaging improve to actually replace ICG as a gold standard for PCV diagnosis? It has some way to go, because at the moment, the polypoidal lesions are not always detected as hyperflow lesions, and so some advances in OCTA to better detect PCV lesions would be better algorithms. So the reason now some PCVs are not detected is because the flow is too slow, and the OCTA needs a particular threshold of flow to be exceeded before it appears as a white pixel instead of a black pixel. So if you change the thresholding of the OCTA, then it's possible to get a white pixel on lower flow, and also then this is what thresholding is about. And also we can identify more non-invasive biomarkers to predict the progression and monitor the response. All in all, thank you very much for this, and we invite you to APVRS in Singapore, which is happening in November, and also there's a Fellows Vitreous Surgery course. With that, I'll take any questions if there is from the floor. Thank you very much.
Thanks, Anna. So, shall we keep the questions to the end?
Yeah, or we can do, because there's some time, so we can do it, because I think each topic is quite different.
Sure.
If there's any questions from the floor?
Maybe I'll start with a question first, Anna.
Yes.
I mean, pardon me, because I am, not so well versed in medical retina now. Now that I'm a bit more of a glaucoma person. So, can you explain what is the reason for the sharp PED and the notch in the PED, right? That you take an OCT that is so specific to PCV.
Yeah, so the peak PED is usually because the polypoidal lesions, which increasingly we know are not actually polyps. So the old word of polyp, whereby it's like a protrusion or a tissue protrusion, is actually a false word. Now people use this word called aneurysmal dilatation of the lesion. So essentially it's a mini aneurysm that comes out from a choroidal vessel. And I think when it has this aneurysm and it sort of grows into a sort of a bigger aneurysm, then it lifts the above RPE into this peak configuration. And this is why also sometimes we know that PCVs grow on the undersurface of the RPE, and it's actually grown above Brooks and underneath RPE, in that RPE Brooks space. And that is why when it grows on the underneath surface of the PED, in a large serous PED, it makes that little notch, which is that little bump on the PED. So I think it's these reasons why the appearance looks quite like that, and I think histology increasingly has proven that's the case also.
Thanks for that. So based on your current practice, do you see that, based on your talk, I can see that there is a lot of potential with the use of OCTA. Do you find that the frequency of you using ICGA now is getting lesser and lesser? And do you ever do away with it? So
I think that was a question also yesterday when we were having the retinal subspecialty day. How much do we need traditional angiography anymore? So I think it's not totally redundant, but definitely its use is reducing, because when you use OCTA and when the membranes are clearly there, when all the features of polyps are like there, you can definitely diagnose both typical AMD, PCV, and a lot of AMDs based on OCTA if the OCTA shows the lesion clearly. However, when the OCTA does not show the lesion, sometimes the OCTA is not 100% specific, so you may need to go and do angiography when there's no lesion seen. For things like planning your PDT, however, I think ICG is still an important modality, because when you plan FFA and ICG, because when you plan a PDT, you want to make sure you get the entire lesion, the entire branching vascular network, and PCV next to it. And also you want to make sure that you see where the areas are leaking, which is on the fluorescein. So there's still examples where angiogram is still important. However, for the diagnosis of typical AMD, a lot of times when it's clear on OCTA, you may not need to have angiogram anymore.
Great, thank you. Yes, sir.
Great presentation. Just a couple of questions. One thing is, how different is PCV with AMD? Because we still treat with the same drugs.
True. True.
This thing, and still we keep on treating, and when do you stop treating them? Because if they are responding, regressing, I can understand. But there are many times we find that because of the blood, the hemorrhage, we have hardly been able to assess them. As long as there is no hemorrhage, all these multimodal imaging have some say. But the moment you get a large hemorrhage, then what do you do?
So I think when you have a large hemorrhage, then it's game over. Actually, because once you have a large hemorrhage, you either do a pneumatic displacement or you have to do a vitrectomy to displace the hemorrhage if you can, and if it's a subretinal hemorrhage, right? But if it is a PED, a sub-RPE hemorrhage, or it's a vitreous hemorrhage, then you just have to deal with it when it's there. But the idea of multimodal imaging is picking up the open polypoidal lesions before they bleed, right? And actually we know that we had a randomized controlled trial that if you do intensive monthly anti-VEGF treatment after 3 loading doses for another 3 loading doses, 30% more of your polypoidal lesions are closed. So in this case, aiming even before the bleed happens to close those polypoidal lesions, be it doing it with intensive anti-VEGF or addition of PDT or addition of focal laser to some of the lesions that are more peripheral, these things stop the bleeds from happening. Because once the bleeds happen, it's like you said, it's game over already.
Any choice of anti-VEGF you would like?
So obviously the longer acting anti-VEGFs, and now I've been using faricimab a lot, and that has, and both aflibercept and faricimab, actually both, are very good with PED treatment, so they actually flatten out the PED much better than Lucentis and Avastin. And I think actually there's been a lot of papers and a lot of presentations on Beovu, brolucizumab, and that as a third-line therapy, obviously, really looking clearly for the IOI signs and everything. But brolucizumab, for those that are resistant to faricimab and aflibercept, have actually been shown to really help reduce the PED size and get the disease under control. So I think these are all options that we have, and as we expand to more and more anti-VEGFs, we'll be able to treat this better. But I think looking for these polypoidal lesions and aiming to close them, and that brings you to the other point, when do you stop, right? So actually, for polypoidal lesions, unlike AMD that always sort of like rumbles on for ages, if you are able to, when you see a polypoidal lesion that has closed and has flattened, and there's a BVN that's very slowly leaking, in a lot of those cases, if you stop, you can actually, stop treatment and just watch them closely.